responsiveness to change. Then activities of daily living is very common in researches. Is very common, though in the clinics is not very common, but it's very common in researches that we assess activities of daily living. What the individual, remember, in WHO has reiterated that rehabilitation has three facets. The three facets of rehabilitation are related to impairment and activity limitation and participation restriction. What relates to impairment is that of inability, is that of what do you call it? Is that of microscopic death of tissue that leads to inability of our nerves or muscle to function properly. Therefore, where there is what they call it infarction in the brain, there is macroscopic death of brain cells that leads to our inability to work. Therefore, what happens in our brain is an impairment. Like impairment measures can be that of what they call it cognitive function. Impairment measures can be that of spasticity. Impairment measures can be those of pain. Impairment measures can be those of range of motion. All those ones are impairment. They are abnormalities in the structure and function of the body, in the structure of the body. Then now this particular structure, if physiotherapists cannot change the structure, there is permanent damage. Then we now look at how do we circumvent loss of function. That is what brings about the issue of disability. If somebody cannot walk, can we give him a walking stick? Can we walk him on parallel bar until he is able to regain function? If somebody cannot see very properly, can we give him, what do you call it, glasses? Therefore, we are circumventing disability. We are trying to make somebody, despite the fact that we cannot return, we cannot correct the lesion that happened in the brain, the spasticity, but we can actually circumvent the spasticity and help somebody to function. That is the issue of activity limitation. Therefore, these activities are what we measure. Now, what are these activities? We call them functional activities. We call them ability of an individual to perform the daily works he is able to do at home. Basic activities of daily living are those activities that has to do with self-care, ability to wear your clothes. You don't want people to be wearing your pants for you. You don't want people to be bathing you. You don't want people to help you go to the toilet. You don't want people to be brushing. Those ones are basic activities of daily living. While we talk about instrumental activities of daily living, are those activities that you can assign somebody to do. You can assign somebody to go to the bank for you. You can assign somebody to drive you. You can assign somebody to take care of your finances. You can assign somebody to cook for you. You can assign those ones that are not very basic, that you can even hire somebody to do. We call them extended activities of what? Daily living. Therefore, what we are saying is after we must have finished managing these particular patients in the clinic, initially they have a lot of impairments. They have a lot of impairment, weakness in the structure of the body. Now we are able to circumvent that. They are able to get some function. Then the next thing is for us to be able to see to what extent is the patient able to do activities he is able to do for himself, or other activities others can do, but he can also help in doing it. Those ones are the extended activities of daily living. Therefore, in the clinic, if we can, what do you call it, introduce this, it will help. We have Adelaide activities profile, 4-point ADL scale, battle index. Everybody near of us knew about what? Battle index. And battle index is actually an inpatient, what do you call it, assessment scale. Usually for patients that are recuperating in the inpatient, we use battle index. But whenever they start coming to physiotherapy department as outpatient, that scale has what? Ceiling effect. Meaning that somebody can score 100 over 100 but still is having functional limitation. That is the reason why we have all these frontier activities index. They are in measures of instrumental activities of the living. We have instrumental activity measure. We have so many of them. Lawton instrumental activities of daily life scale, Nottingham extended activities of daily living, Nottingham lecture questionnaire, Nottingham stroke dressing assessment, Rivermate activities of daily living. All these ones are questionnaires, what do you call it, skills that are meant to measure one's ability to be able to do all other activities is what do you call it, prior activities before stroke, to the extent based on the extent of his what do you call it, impairment. Then here I introduce the Nottingham extended activities of daily living, the needle. We have is a major consisting of 22 functional tasks: walking, cooking, cleaning, participation in active hobbies. These tasks are then further divided into four distinct subscales: mobility, kitchen, domestic. You can see all these ones are relating to activities one does in his house. And in turn, each task is what you call it, measured on a 5-point ordinal scale. 0, somebody cannot do, and 4, somebody can do on his own without. Therefore, we have other scoring. We have scoring 1, 2, and 3. Then the next is participation. Remember, WHO also highlighted that it's not just enough for you. These are domains of what you call it, rehabilitation. When you look at impairment, if you cannot treat impairment, then circumvent disability, therefore ensure that there is activity which we have assessed. Then finally, we have to ensure that participation is maximized. Somebody should go back to school. Somebody should go back to his work. Somebody should go back to other leisure activities he's able to do. Somebody should go for social interactions. Somebody should be able to attend churches and mosques. Those ones are participation, meaning that if somebody can walk and somebody can wear his clothes, you have achieved activity, then why can't he go for social gatherings? Therefore, we have stroke impact scale, Canadian occupational performance measure, London handicap scale, life habit questionnaire. We have so many participation measures. I just mentioned some few here. Go. Participation measures, and each one has the construct it uses. Some assessed actually, and as I mentioned in the morning, where you have participation is increasing, the score is increasing with participation, then it measures participation. Where the score is increasing and it's telling you that it's negatively scored, the higher the score, the lower the participation. Is measuring more of disability than participation, but all of them can be used because the lower score meaning that what better what do you call it, participation. Here I introduce life habit assessment. Remember, life habit questionnaire, I used it before. It has 12 domains. And each domain has to do with one activity, even choice of food, preparation of food, everything that has to do with house chores. They are what do you call it, assessed. And what do you call it, interactions even within the house and outside house are being assessed by the life habit questionnaire. Then it has two main domains. We have apart from the what do you call it, the 12 apart from the 12 subdomains, then we have two participation areas. We have performance in the accomplishment of daily activities and social roles and satisfaction with this performance. There are two different scales. When you check life habit questionnaire, you are going to see there are two different scales. After the domains, each activity one is able to do, they will now you have to rate. How is he able to accomplish these tasks? Then you have to rate again satisfaction with the performance. This is the way it is. We have short form consists of 77 items and 12 life habits domains. Therefore, the performance is assessed on a top, what do you call it, 10-point scale from 0 to 9. 0, somebody is unable to participate in those activities, and 9, individual is able to participate fully in the activity. Then the next assessment, remember we said assessment of stroke patients is multifaceted. What we mean by multifaceted is that you have to assess impairments, you have to assess activity and activity limitation, and you have to assess participation and participation restriction. Therefore, the next is the issue of cognition. Cognition is an impairment variable. Just the way you see spasticity, the way you see aphasia, the way you see pain, all those ones, the way you see impairment of muscle strength, weakness, all those ones are impairment because they have to do with what? Affectation of body structure. Therefore, we have cognition. This outcome measures assess individuals' overall cognitive assessing capability, factoring in multiple domains. Why I brought these ones is, please,
Yes.
there are individual items. There are skills that assess individual domain of cognition. Therefore, the skills I brought before you, they are the ones that assess, is like global assessments. They have so many domains that one can easily break them down. Therefore, if you have those people that are actually very vast in assessment of cognition, they will tell you there are instruments that can assess different domains of what do you call it, of cognitive function. Therefore, we have the Barrow Neurological Institute screening for higher cerebral function, short portable mental status questionnaire by paper. I know this one. We have mini mental state examination, MMSE. We have cognitive test 50, functional independence major, cognitive subscale. Remember in our what do you call it, functional independence major, it has the normal functioning that we use to assess activities of daily living, and there is a cognitive subscale that is attached to it. Then we have Montreal Cognitive Assessment, the MOCA. We have Raven's Progressive Matrices. These ones, I think there was a time I presented something in pediatrics. This one is not free, but one can do it online. We have Wechsler Adult Intelligence Scale. It's also not free. One has to buy the set of assessment kit. Therefore, I gave example of two. We have mini mental state examination, which has 30 items, and it consists of 11 questions with that as I and in that which are spread in 7 cognitive domains: orientation to time, orientation to place, registration of words, attention and calculation, recall, language and visual construction. Therefore, we said the severe, remember I told you about these questionnaires. I'm not going to discuss them at detail. All you just need to know is any score that is between 0 and 17 is denoting severe impairment of cognitive function. Therefore, we have moderate from 18 to 24, and we have mild anything 18 to 23. From 24 above, we have mild cognitive impairment. Therefore, they said although MMSC is the most widely used screening tool for cognitive impairment, its greatest limitation is lack of sensitivity in identifying small changes, meaning that somebody who did not improve as much, if the changes is not big, it's very, very small, then they say it may not detect, meaning that it detects changes that are a bit larger. Then we have the Montreal Cognitive Assessment, the MOCA. The most important thing you should know about MOCA is that it is easy to administer, but if somebody is trained, therefore they have it there written. Go and check MOCA. They said it requires some training. Therefore, if you need training, go come and see Dr. Abba. He will train you on how to use MOCA. MOCA is a screening tool for cognitive impairment. 11 items relating to 8 cognitive domains. We have them here: visual, spatial, executive functioning, naming, memory, language, abstract, delayed, recall, and orientation. They said maximum score is 30. Therefore, any score that is greater than 26 is considered normal. Administration approximately 10 minutes. But it's not the 10 minutes. You know how to administer it. I think there are other things you need, like stopwatch and all these things. Therefore, when you come, our meeting is going to teach you. Therefore, the next is, remember we said the presentation is not arranged in such a way that we talk about impairment before activity, before participation. We just mix them up. But based on my presentation, you should be able to, what do you call it, say the difference. Here we have unilateral spatial neglect. Here is also another impairment. But this particular impairment occurs in patients with right hemispheric stroke. Remember, people with left hemispheric stroke have right-sided affectation. Everybody in physiotherapy know that aphasia will occur. 90% of patients, aphasia. Oga, we call unilateral spatial neglect. Shikuma, it affects what do you call it? Right hemisphere. Therefore, those people with left-sided affectation are the ones that are likely going to be affected. Then, if you go and check literature, both left and right hemisphere control what do you call it? Spatial function. But the issue is that the right hemisphere control both left and right, while the left hemisphere control only right. Therefore, if the left hemisphere is affected, no problem, because the right is controlling both left and right. But if the right is affected, then it will show. That is the little explanation for that. Then, how do we now recognize individuals that are having neglect? Some people say we should start checking neglect 30 days when not up to 30 days when the patient is having stroke, meaning that for us to reliably begin to know that this patient is having neglect and to be able to take care of that neglect, what do you call it, in time. They say we shouldn't allow until when the patient finish inpatient, what do you call it, rehabilitation. Within the first 2 weeks, start to look for neglect. If there is neglect, then you now take care of it. Then how do we now recognize neglect? You give somebody food to eat. He will eat on only one part. The other part is left. the patient did not actually recognize that there is food on other part of the body. Remember, we said the left people with left-sided stroke are the ones that are affected. Therefore, anything on the left side does not exist. Therefore, when you give him food, the patient is likely going to use his right hand to eat. And then remember, based on religion, based on culture, definitely somebody is going to use his right hand to eat. But anything on the left, he will leave it. Then that means there is neglect. They say unilateral spatial neglect, it is defined as failure to report, respond, or orient to sensory stimuli presented to the side contralateral to the lesion. Remember, contralateral to the lesion is left hemisphere, therefore the side is right-sided. Therefore, anything on the right. And then if we realize this, then physiotherapist should always approach the patient on the side that is affected. Rehabilitation should always function on the affected side. If not, that side is not going to be, utilized by the patient. More obvious form of neglect involve colliding with an environmental object. Somebody walking, like for example, in our clinics, you may have some pillars that are helping to hold, roof. A patient will just collide with one of the pillar. He has forgotten that there is a pillar because the pillar is on the side that is affected. Ignoring food on one side of the plate, I have said it. Attending to only one side of the body. Therefore, the issue is what we are really saying is if there is neglect, then the patient will not be able to, there will be misuse. The patient will not be able to use the side that is affected. Then we have, please, there are almost 5 measures of neglect. But these 2 measures of neglect are simple and reliable to use. We have the line bisection test and we have the star cancellation test. In the line bisection test, let me show you if you are seeing. Can you see the screen? I have seen, look at the lines here. The first one on the A part, the lines are, the requirement is that the patient should indicate, draw a line in the exact middle of that particular horizontal line. Therefore, or you make a point in the exact middle of the horizontal line. Look at the B part. The patient with neglect will not be able to, get the middle part of the line. Therefore, if there is up to 6 millimeters of difference of distance between the exact middle of the line and where the patient is functioning, and in several places, is a sign that the individual has neglect. Let's go back. We have line bisection test, consists of series of 18 lines for which the patient are asked to mark the midpoint of each line. Scoring is completed by measuring the distance between the true point and the line the mark, the patient's mark. Therefore, this is the true distance. This is the true middle. At the distance between the middle, point and the place where the patient now strike that particular line is measured. If it is more than 6 mm, then it's indicative of unilateral spatial neglect. But still, that is not sufficient. They said it may also suggest that the patient may likely omit 2 or more lines. Therefore, you now check. There are 18 lines. The lines that are much, much closer to the place that is affected, he is likely going to miss them. If he missed 2 or more lines, it's another indication that the individual is having what? Unilateral spatial neglect. Then, star cancellation test. In star cancellation test, we have a picture that will be shown to the patient with 56 small stars, 52 large stars, 13 letters, and 10 short words, all in one place. Then the patient will be asked to cross out all the small stars, meaning that the patient will be asked to cross out all 56 small stars. The right and left sides are compared. Therefore, what happened is you now ask the patient on the side that is not affected, the normal side, you ask the patient to do it. Then you see that okay is okay. Then you now compare with the affected side. They said if individual did not correctly cancel up to 45, he canceled between 0 and 44, meaning that that individual is having neglect. Remember, there are 56 small stars. Therefore, if the individual is able to correctly cancel out more than 44, up to 45, 46, 47, she can. If it is from 0 to 44, it's a sign that individual is having severe neglect. Then the last one, that is the overall. Oga pata pata, after you must have done everything, you have managed everything. The next thing is Remember, we talk about impairment. If you are unable to manage the impairment, then you should circumvent disability and you make sure that the patient participates. All these ones are to make the patient happy, to go back to productive work, to be able to earn a living. And finally, we have quality of life measures. Quality of life measures are measures of our overall well-being, measures of how we function in life, how we enjoy life from what we value. You see, in US, what people value probably they value privacy, they value what do you call it? They value being lonely, they value some associations with people they like. In Nigeria, we value money and probably food. Therefore, what happened is quality of life of person in the UK is different from the way he perceive life, the way he understand life is different from us in Nigeria. Therefore, if you get electricity, quality of life is good. Their electricity, it's not a problem. Therefore, these outcome measures assess individuals' overall quality of life and their perception of it. Therefore, please, perception of quality of life is different across people and across region. We have Australian quality of life, Dortmund co-opt chart. We have you recall quality of life. You call it EQ5D. We call it you recall 5 dimension. We have life satisfaction index. We have medical outcome trust short form health survey. That is SF36. We have SF36, SF12, all those short form health survey. We have Nottingham health profile. We have stroke specific quality of life questionnaire. It is meant for stroke patients. Then we have Pielman quality of life scale. We have satisfaction with life questionnaire. All these ones are there. Then I now took one of them. I said, okay, stroke specific quality of life is a patient-centered outcome measure intended to provide assessment of health-related quality of life specific to stroke survivors. Therefore, it has 49 items, 12 domains: mobility, energy, upper extremity function, work productivity, self-care, social role, everything that has to do with them. If you go by what the producers did, they did a lot of work. They do interview with the patients, the health professionals before they come up with this particular scale. Therefore, it's good. Then the second part of our presentation today, we have presented the issue of assessment in stroke. Remember, there are some things I did not do. I cannot talk about assessment of sensory function, assessment of reflexes, assessment of proprioception, assessment. There are some assessments that we believe as physiotherapists we should be able to do them. Like I will not be able to be telling you assessments of let's say what do you call it, Babinski reflex, what do you call it? Yes, all these ones we believe you as physiotherapists you have they are at fingertips. You should be able to do them. Go. Therefore, these ones I talk more of assessment generally that has to do with use of what do you call it? Outcome measures. Then we have goal setting. When we said we want to set goals for our patients, definitely, right from when we now begin to assess for what do you call it, severity, like using the NIHSS scale, using the Canadian what do you call it, stroke scale, and all these ones, using even Glasgow coma scale, we should be able to set goal for our patients. What are these goals? These goals are what we want the patient to achieve. They relate to prognosis of the condition. They relate to severity of the condition. Because the more the severe the condition, the less we demand that the patient should be able to achieve something. Therefore, they said goal setting has been described as one of the skills that specifically characterizes professionals involved in rehabilitation. Meaning that we that are in rehabilitation, we should be able to say, usually in goal setting, I would say Mr. A should be able to wear his clothes in the next 1 month. Mr. A should be able to walk within his house in the next 1 month. I should be able to say Mr. A should be able to return to his work in the next 6 months or in the next 3 months. I should be able to say Mr. B should be able to work without any support and outside the house in the next 30 days. That is goal setting. We set goal for our patient based on our assessment of the patient. However, it has been shown that there are barriers to overcome. As therapists and the patients may have different goals, and therapists may not be willing to accept patients' goals. Yes, the patient may tell you that I'm a manager of the bank. and I want to go back to the bank and be signing my check. And then he only signed his check using his right hand. And he has a very dense stroke, a severe one that you know it may not be possible. Therefore, the major big problem that we have here is you have to sit down with the patient, tell him what is possible and what is not possible based on the degree of impairment of the patient. And then you can train the individual to sign even if it is with his left hand. One thing is there are some patient's goals that may not be achieved by you. Somebody is a truck pusher. He used to carry heavy load and he has stroke. Do you think it's going to be possible for him to be carrying just heavy bag of rice on his head again? It may not be possible. There may need for him to change his work. Conflict between patient's goals and therapist's goals for the patient may arise if the patient pursues goals that the therapist believe to be impractical and unachievable. But there is always a way that we sit down with the patient. There's always a way that we interact with the patient. There's always a way that we create a rapport so that the patient will trust all that we have said to him. Therefore, guideline for goal setting. One, it involves the patient's early process. One, goal setting and goal revising. They said we should involve the patient early in the process of goal setting. Therefore, when we want to set the goal, we can start setting short-term goals. In the next 2 weeks, what do we want you to achieve? Then, if we want to revise the goal, after he has achieved a goal, and we want to revise the goal, we should set it together with the patient. That is one of the guidelines. Two, inform the patient about the possible anticipated needs. What are the needs of the patient? What are the needs? And he should also be able to tell you all his needs. Yes, part of my needs as a housewife, I should be able to be cooking food for my husband. This was the anticipated need of a woman who is married. She wants to be attending to her husband, to negotiate goals with the patient and reconstruct the goals when necessary. Now, the patient is saying, I want to achieve A, and the therapist knows that A is not going to be achievable, but B can be achieved. Then they can negotiate. That is why they said they negotiate the goals. The third one is use clear and open communication. What happened is we shouldn't use jargons. Tell the patient something in a simple language that he understands. The issue is that the patient should also remember in physiotherapy, we don't just give like drugs. Patient take it. Even drugs, if the patient is not happy, the patient is having depression, the patient may not even take the drug. Talk less of you that gave him some exercises to do at home, some activities to perform. If there is no clear instruction and there is no understanding and the patient is not willing to help, then the patient will not achieve what you want to achieve. Encourage the patient to consider the values of his or her social framework and the impact of decision upon family members. What we are saying is the patient should understand that doing things for himself will relieve his children of some burden. The children would probably have to leave their job, come and take care of him. Some family members will have to keep supporting him coming to the hospital. Therefore, if he sees the reason for him to join you in the management so that he gets well better, then it's going to relieve so many pressures on so many people. Pressure of finance coming to the hospital, pressure of his people staying with him, pressure of burnout. Somebody doing nothing, sitting down to just take care of a relative. Therefore, we said you should have a clear functional goal. The goal, they said, determine the patient desired outcome of therapy. We have said it. We have to know what the patient want to achieve. Understand patient self-care, work, leisure activities, and environment they occur. Yes. Therefore, in our clinic, actually, this is white man is a little bit different from us here. What we do is the highest we ask the patient, what is your occupation? But actually, we never even take care to know the nature of the work he is doing, how is he able to perform the work now, his leisure activities, whether he performs some activities on his own, like leisure time walking, leisure time, activities on his own, whether he wants to go back to them, and then in which environment did he work? What is the environment? Which environment did he live? Is it possible for somebody with stroke to go back to that environment, or he requires some rehabilitation to go back to that environment? Is he staying upstairs in his house? Is he staying downstairs in his house? Does he need to climb stairs? All these ones are very important. establish the goal with the patient that relate to the desired outcome. We have discussed this. They said qualities of functional goal. If we want to set a functional goal, they said it has quality, respect for patient values. Meaning that when I set a goal, I just want the patient to walk. And the patient says, walking alone is not enough for me. There is gutter in front of my house, and I want to also be able to negotiate this gutter. Then I have to respect his values, because if not, he's going to fall inside that gutter. He has a staircase in his house. Therefore, I should be able to respect that this patient should be able to climb staircase and express it. They said the goal should be smart, specific, consistent, and attainable, meaning that we should be specified specifically, meaning that when we identify, there is in the next slide we are going to see the issue of identifying. I think we used to say what are the functional limitations of this patient, but we said what can the patient do, what can the patient not do. Part of assessing the patient's functional limitations that will help us to develop what functional goal that are specific. Can you see, Baba? Yes, you cannot do sit to stand. Talk less of walking. Part of it is in the next 1 week, the patient should be able to stand from sitting position and be able to walk. Or probably stand from sitting on a mat. Probably he can stand from sitting on a chair that has armrest, but he cannot stand from sitting on a mat. On a mat should be part of this. They said it should be consistent. Let the what do you call it goal be the same goal this week, the same goal next week until we achieve it before we now change our goal. Let it not be that today my goal is this, tomorrow my goal is this, then we confuse the patient. And attainable. We should set a goal that we and the patient should be able to attain. They say same for therapists and patients. We have said this several times. And then the next is this slide. I call it the banner again. Okay. They said, what are functional abilities of the patient? They said identify functional problems. You can never set goal without identifying the problems. The patient should know this is his problem. You should also tell the patient this is the problem. Then what are the functional limitations of the problem? The patient. Formulate the desired objective for management each of the identified functional limitation. Each one. For inability to walk, what do we do? For inability to stand from sitting position, what do we do? For inability to climb stairs, what do we do? For inability to walk long distances, how do we help you? For being so tired, if the patient start walking immediately after 2, 3, 4 steps, what do we do? Fatigue is setting in. What do we do to achieve endurance? All these ones, each one of them will set goal for it. Then they said long-term goal. Now look at the characteristics of long-term goal. They will need to be set with the patient first while considering the following. They said etiology and clinical manifestation of the condition. If you are setting long-term goal, you should set based on the severity of the condition. Can the patient in the long-term goal are ambitious? You want the patient to be able to wear his clothes, the patient to be able to go back to playing table tennis. The patient should be able to drive his car. The patient should be able to do some other things that he is able to do before, like play football. Yes, those ones are long-term goals. But they said what? We should look at the clinical manifestation of the condition. Actually, can he be able to do that? Likely prognosis and anticipated recovery. Will he recover to that extent? Patient objectives and perceived needs. Vis-a-vis, what did the patient actually tell you he want to achieve? The third one, patient personal circumstances. There are circumstances of the patient, like a civil servant working in a particular private company. That private company, if he cannot function 100%, they are likely going to sack him. This is a personal circumstances of the patient. Patient working in his own factory, no wahala. But patient working in bank setting, in one place where actually if he cannot function, they would have to sack him, then the long-term goal should, reflects ability to go back to his work. Then both long and short-term goals are time-bound. What they are saying here, they said it's wrong for me to say the patient should be able to wear his clothes again. They said no. They said I should say the time in the next 2 months. Because me and the patient will work towards achieving that in the next 2 months. They said goals time bound. You should always say it in relation to time. Then they said short-term goals. What are short-term goals? They say they are relevant to long-term goals. If long-term goal says somebody should be able to go back to driving, then what are short-term goals? Then the short-term goals should relate to somebody being able to drive. All those activities that will be able to make him drive should be part of what? The short-term goal. Functionally based. Remember, all goals are functionally based. Remember, there was something we said. Please, I think it's in one of these slides. I'm unable to see that one. Usually, we say functional goals are what do you call it? Are concrete, not abstract. Somebody will say, what do you mean by concrete goal? What do you mean by abstract goal? Let me give you an example. If I raise my hands up, the two hands, as if I'm surrendering to somebody showing me God, and somebody says, I did work. Yes, I did work, but this is what you call abstract. If somebody says, you raise your arm, yes, I raise my arm, but it's abstract. But if I use that arm to pluck mango, then it has become concrete. I have done job with the hand. If I raise my arm and that arm, actually I bring it back, call it functional activity, but actually it's not concrete. It's not task specific. What happened is, if I raise my arm, I should be able to use the arm as I raise it to do something. Therefore, everything we do to the patient that is functional should ensure that somebody achieves something. They say capable of objective confirmation. What is objective confirmation? Last week, I told you this week, you will be able to walk 10 meters. Today, you are able to walk 10 meters. That is short-term goal. Tomorrow, I said, you feel tired so easily. I am timing you after 3 minutes. You become tired tomorrow. I want you to walk until you reach 10 minutes. Somebody is able to reach 10 minutes. That is what? Objective confirmation. They said agreed by rehabilitation team and the patient. If you have a team, the short-term goal, please, both the long-term and short-term goal should be agreed by the patient and rehabilitation team. They say it's feasible within what? Time span of rehabilitation. Now, there is something people should understand with short-term and long-term goal. Short-term goal is always achievable within the time span the patient is with you. All those ones are short-term goal. But long-term goal can surpass the time the patient is with you. Like you can discharge the patient but based on what you ask him to do, he should be able to go back to playing football. He should be able to go back to playing, going back to his work. He should be able to go back to his swimming. He should be able to go back to all other activities he's doing. It may not be that the patient should keep coming to physiotherapy department. You must have discharged the patient, but long-term goal, based on your plan of long-term goal, the patient should be able to achieve that. But short-term goal, they say it has to be achieved when the patient is with you. That is one difference between long-term and short-term goal. Meaning that long-term goal can have what you call transfer package. Transfer is that you have achieved some part of it, but based on the achievement, the patient will achieve more even after you must have discharged the patient. That is all. Okay? And then in conclusion, we say successive stroke rehabilitation is dependent on good management techniques, robust outcome assessment, and efficient goal setting. I thank you for listening, and I thank Dr. Abba for coming to my help. If not, we would have done morning, what do you call it? Things that happen in the morning. I think I'm going to look at my system again. Thank you for listening. Comments, contributions, questions. Amma bana jin abin da suke faɗi. They will talk more. To kai idan
Wannan kullum a haka take
you
kenan.
hear me?
Yeah. Hello, Prof. Good evening, sir.
Ba sa iya magana.
Hello, sir. Can you hear me, sir? Hello. Good evening, sir. I have a question, sir.
Sai ta kamar shi kenan. Gaskiya ne, cikin ma iya kai.
Good evening, participants. Prof has just concluded the very educative presentation on goal setting among stroke survivors. So if you have any question or contribution, you can write on the chat section, or you can unmute yourself and ask the question. We are waiting. Yes, somebody posted, I have a question, sir. Yes. Can you type the question, or you raise your hand up, then you can unmute. Prof is here waiting. Yes, Sani Olabi Suleiman, can you unmute?
Yeah, good evening, sir.
Yes. Can you state your question?
Thank you, sir, for the presentation. Thank you, Prof, for the wonderful
Someone raised hand and
this presentation
sorry, we
is
can't hear you.
Can you hear me now, sir? Am I audible? Hello, am I audible? Am I audible? Hello?
Hello?
Hello? Can you hear me?
Yes, we can hear you now.
Yeah, can you? Okay. So
Yes,
I want to thank
Prof is here
the
listening to you.
prof.
Yes.
Thank you, sir, for the presentation, sir. First of all, presentation is a very important one, especially for us in the neuro practice.
Yes.
So, just an observation then. Please, I
Okay.
don't know who is the admin controlling the presentation. Whoever is disturbing is that they cannot be removed, because I was just distracted background noise here and there. I don't know where that one is coming from. So my
Yes.
question is concerning the assessment, and because I missed the morning section. I don't know if materials will be available. I would appreciate that. So my question is there any updated what's it called, updated style of assessing, and putting a patient planning a patient rehabilitation on, because I've attended and seen different, everybody come with their own school of thought, and I feel is there any updated or new style of assessment for stroke patients or any of the patients that have a neurological condition that really suits rehabilitation of such patients? Thank you, sir.
Okay. Thank you. Can you hear me now? Hello. Actually, I thank you for this particular question, and this is where hospitals and physiotherapists that practice in the US, UK, and all other places, I think this is where they surpass us. Therefore, in every setting, there should be, the neuro unit should develop based on what we have here. They should come and arrange. Usually you'll see which hospital, at times you see the name of a hospital now coming up with what they believe that this is what they should, how they should arrange for the assessment of patients that have stroke. Therefore, me in academia, I'm a researcher. But the most important thing we should know is that these assessments are very important for the patient. Then how we arrange them to suit us, assessing everything that's to do with the patient, it depends on the unit and the hospital. You can sit down and come up with it. Okay, usually my advice is start with impairment first, because impairment is the one that brought the patient down. Impairment of motor function, impairment of infarction of our brain. Therefore, everything that has to do with impairment, deal with it first. Then in your scale, the next in what you want to achieve is patient being able to do something for himself. That brings you the issue of what? Activity. After activity has been achieved, remember when we talk about impairment, pain is there, spasticity is there, all these ones. I think we used to do them. The only thing is that to arrange them properly. Okay, impairment measures of impairment first, because they are the ones you deal with first. Then coming back to activity, coming back to what? Participation. Therefore, all this neglect we are saying, all these cognitive related issues. Now, there are some things I told you that we cannot cover. Issues with depression in early phase of stroke. Somebody saying the life has come to an end, this. You have to deal with that. If not, the patient will not even concentrate. Therefore, the most important thing is, based on my little advice, as a stroke rehabilitation team, come up with, arrange this particular what do you call it, assessments from impairment, activity limitation, participation restriction, then set goals based on each one of them. And before you know it, you are going to come up with robust assessment for your patients in the hospital. Therefore, and it's also going to help you training interns and the rest. Whoever come, this is how we assess. You have to assess this, then later this as the patient is improving. Then sky is our limit. Thank you for the question.
Thank you, sir. Thank you. Much appreciated, sir. Thank you, sir. Thank you.
Ruwa sa wannan. Kuma ciwo. Ruwa na.
Yeah.
Yanzu an wa mutane
Hello, Prof.
karuwanci.
Hello, sir. Good evening. Hello, can you hear me? Hello. Good evening, Prof.
Yes, we can hear you.
Okay, sir. Good evening, Prof.
Okay, good evening. How are you?
I'm very fine, sir.
Hello.
Yeah, I want to first appreciate you for this robust and educative workshop this
Thank you,
evening.
sir. Thank you, sir.
Yeah, thank you so much, sir. Even though I missed the morning section because of the technical issues that was experienced.
Yes.
Yeah, I was really not happy about it because I would have loved to be in that session.
We are going to
So,
give you the material. By God's grace, you are going to understand it.
okay, that would be much appreciated.
Yes.
And I just want to ask, I don't know, a simple question, maybe it's not simple too. Is
Okay.
there any more effective way, of managing the upper limb spasticity, or the affected upper limb of a patient, of a stroke patient? Because I've come to notice that it's always an issue. I mean,
Yeah.
it's more difficult to restore the function of the affected upper limb. Okay,
Yes.
the lower limbs can respond so fast. Okay, but the
Yes.
upper limb tend to be, a more headache to the physiotherapist.
Yes.
So I don't know if there are more, updated, clinically proven interventions that can
Okay.
really help the physiotherapist. There are more effective means, of restoring function. to that
Okay.
upper limb.
Okay.
Thank you, sir.
Thank you for the question. Let's look at your observation in two phases. You see, the first one is it depends on the extent of affectation in the brain. There are individuals with upper limb, what do you call it, weakness that persist for a long period of time. They have what you call dense stroke. Somebody whose upper limb remains zero for almost 5-6 months. There is nothing what physiotherapists can do because the affectation in the brain, if you go back to sensory homunculus in the brain, you now see the areas that are being controlled by the hand are much more larger than the areas are being controlled by the leg. That is why when somebody has, most especially middle cerebral artery lesion, hands are usually more affected than the leg. If the lesion is big, that is why we said either focal or global affectation of cerebral function. If the lesion is large, the upper limb function is going to be severely affected more than the lower limb function. That's one. And then remember the difference between upper and lower limb is that there are instances we have strokes that lower limb can be affected, most especially anterior cerebral artery lesion leads to lower limb being more affected than upper limb. But in most instances, where you find upper limb more affected than lower limb is middle cerebral artery lesion. And then if it is more widespread, that is when you now see stroke patients spending 5-6 months without having any, useful movement in the hand, probably flicker of movement or so. But now let's come back to the issue of spasticity, sir. The most important thing we should note about spasticity, you should be able to control spasticity before it sets in. In my practice, I observed something. All those that travel to UK, even Egypt here, they never develop that upper limb flexion synergy. Why is it that our patients that have spasticity, they have severe spasticity in the upper limb, that the hand is bent and contracted bent at the elbow and wrist? Is because we don't use orthotic device. I saw one very beautiful orthotic device that is placed on the patient of a hand, on the hand of a patient that came back from Egypt. They don't wait until spasticity sets in. They give him cock-up splint for the wrist, and they give him front slab for the upper limb. Therefore, you do exercise, they can be using those ones as night splint while you continue managing the patient. That is number one. Number two, apart from apart from the severity of stroke, the rehabilitation for upper limb usually is a bit more complex, most especially when the patient has delay in return of function. But if one can have at least a power of 1 or 2, you build on that. Therefore, the advice I'm going to give is that for the patients that want to achieve something with the hand, those rehabilitation of coming twice or once weekly to the clinic, gaskiya should not suffice. Therefore, there should be augmentation, even if the clinic is so so busy that the patient cannot be entertained one and more than 2 times in a week. Then there should be augmentation with home-based exercises, most especially that involve the upper limb. Upper limb rehabilitation, there are so many things one can do with the upper limb, but the major issue is get at least a movement. If it is 2, you augment with that. Remember, I am an advocate of task-specific training. There are other techniques that can help the patient achieve upper limb function, like mental practice, action observation. All these ones, they prove effective. Patient can be observing you doing it. They believe that it improves cortical reorganization. Therefore, please, the more repetition. Let me borrow from my teacher, Professor Akimpelu. She believed that even if one is doing passive movement to the patient, passive movement for every group of muscles should be at least 50 times. Passive movement to bicep 50 times, passive movement to the tricep 50 times, passive movement to the wrist flexors 50 times, wrist extensors 50 times. The more you do, the better. Even the advocates of task-specific training, they believe the more repetition, the better. Therefore, the little movement one can see, we augment on that. We do a lot of repetitions. Now people are talking about 300 repetitions per session, 400 repetitions per session. This is what is going to work. Therefore, three things matters here. I have talked about them. The most important thing is we have to augment on what the patient is able to achieve with a lot of repetitions. That's one. The second thing is, even if it is passive movement, we shouldn't say, okay, this is passive movement. For each muscle group, there should be at least 50 repetition of passive movement for each muscle group in the hand. That is two, meaning that whether active or passive, there should be intensive practice in the upper limb. The third one, even if somebody cannot move, there are some techniques of rehabilitation now. They talk about what do you call it? Mental practice, action observation. Go and read about them. They also augment patient seeing what you are doing, practicing it mentally, even if what do you call it, the patient cannot do it. They said it reorganizes the brain. There is this neurotherapy also holds. Remember, I talked to you about what the detrimental team that did not usually allow us to achieve effective rehabilitation of upper limb. That is severe spasticity. We shouldn't allow spasticity to set in. I have seen 3 or 4 patients that goes abroad. They come back without spasticity, but they have been fitted with what do you call it? With upper limb orthosis, such that spasticity will not set in. Therefore, even when spasticity sets in, it is never going to be so severe. I think I should be able to say that I have answered you.
Yes, thank you, Prof. Thank you so much, sir. Yes, I'm really happy with your response towards that question.
Okay.
Thank you so much, sir. Yes.
Okay. Any question again or comment? Let me check through the comment section. There is a question there asked by Ibrahim. Is there any tool or outcome measure that assess both basic and instrumental activities of daily living at the same time? And I believe Dr. Adamu is trying to respond to the question. Dr. Adamu, we have in our midst the chair of the Nigeria Society of Physiotherapy, Neurorehabilitation and Mental Health Speciality Group of Kano State, Dr. Adamu. Your comments, sir. We just need additional clarification if you are close by, sir. Okay, I think he's off. It's maybe his network or something.
Okay, let me respond to him. Actually, for now, we don't have one instrument that measures both basic and instrumental activities of daily living. Therefore, we use both of them. Even in researches, we use both Battle Index and what do you call it? And instrumental activities of daily living index. Therefore, you can choose any one of them. For now, it's the practice. We use both of them. We assess both basic and instrumental activities at the same time.
Okay, thank you very much, Prof. If there is no any question or comments, we'll bring to the end of this presentation, and until another time that's scheduled for another presentation, which we are going to listen. Okay, there's a hand raised again. Yes, sir.
Yeah, thank you, sir. It just was for this wonderful presentation. Can you hear me?
We can hear you, sir.
Okay, yes. It's really a wonderful one. This
Thank
is
you,
what
sir.
we need to grow as physiotherapists. Okay, keep on updating and refreshing our knowledge. Yes, and I wish we can have more of this.
Yes,
It
sir.
will really be wonderful as a neuro group. Thank you so much.
There's a schedule already for about 3 or 4 presentations coming up by the group, which has already been shared on the platform. And when the time comes, the link for the Zoom meeting will be shared also, as it was shared today. Thank you very much all for the attendance and for your time. We hope to see you next time. Good night.
Thank you, sir.
Good night,
Thank you,
everyone.
sir.
Thank you.
Thank you, sir. Thank you, sir.
Thank you very
Thank you,
much.
sir.
Thank you.
Okay.
Thank you, Prof. Thank you, coordinator. Thank you, everyone. Thank you.